regarding your bariatric surgery, right? Now, so the question asks you is identify as a procedure: a sleeve gastrectomy, gastric bypass, gastric band. Option D, none. It is absolutely a simple, straightforward question where the answer is your sleeve gastrectomy. So, what you see over here, that this is your resected portion of the stomach which has been removed like a sleeve, right? And so this is your gastric sleeve. So this is your resected portion of the stomach. So this images of sleeve gastrectomy. Now let's take a look at some of the important points or topics that have been asked in your bariatric surgery, right? So if you see the obesity chart, now how do we classify? We classify it on the basis of BMI. I'm sure everybody knows what BMI is. It is body mass index, right? So what is your normal BMI? Overweight, class 1 obesity, class 2 obesity, and class 3 obesity. Normal is your less, so not, sorry, not less than, it is around 18.5 to 24.9. Overweight would be 25 to 29.9. All values are in kg meter square. Then what is your class 1 obesity? Class 1 obesity will range from 30 to 34.9. Class 2 obesity would be from 35 to 39.9. And your class 3 obesity would be more than 40, right? So now for children, what it is BMI defined as above the 95th percentile, 95th centile on your growth chart. So these are some important definitions which could be just asked as a true and false statement in some of your questions. So you need to remember this classification of obesity where normal is 18.5 to 24.9, less than 18.5 is undernutrition. Overweight is 25 to 29.9. Class 1 obesity is 30 to 34.9. Class 2 obesity is 35 to 39.9. And class 3 obesity is more than 40. Now for children we use growth chart, so it is BMI above 95 centile, which is considered to be obesity. Now there is another important term which you need to remember is your morbid obesity. Now what is this definition of morbid obesity? So it is 100 pounds above the ideal body weight, right? So 100 pounds above the ideal body weight, or if it is twice the ideal body weight, or BMI more than 40 kg per meter square. So these are few of the not few, this is the definition of the morbid obesity, which is 100 pounds above the ideal body weight, twice the ideal body weight, and BMI more than 40 kg per meter square. So if you ask regarding the definition, please look at these three values: ideal body weight and the BMI, 100 pounds above the ideal body weight or twice the ideal body weight, and BMI more than 40 kg per meter square. Now what are your indications for surgery in bariatric surgery, right? So if you have BMI more than 40, right, and BMI more than 35, so the catch over here is BMI more than 40 with or without any comorbidities, right? You will consider the patient for surgery. And in case of BMI more than 35, specifically with comorbidities, right? And the other indications include failed dietary therapy, a motivated individual, and there have been some recent upcoming indications of bariatric surgery which include type 2 diabetes mellitus and class 1 obesity who do not achieve substantial and durable weight comorbidity improvement with non-surgical methods. So these are some of the upcoming indication, and remember that the indication for surgery is for BMI more than 40, B or B not without any complication, and BMI more than 35 with comorbidities. Right. Now we move down to the types of bariatric surgery. So they're divided into three broad groups, which are malabsorptive, restrictive, hybrid. So what are your examples of malabsorptive bariatric surgery? They include biliopancreatic diversion. Right. Then what is your restrictive type of bariatric surgery, which includes sleeve gastrectomy? Then it includes your gastric banding, and your hybrid procedure includes the omega bypass or the gastric roux bypass, which is your roux-NY gastric bypass and omega gastric bypass. So types of bariatric surgery, three broad groups: malabsorptive, restrictive, hybrid. Malabsorptive is the biliopancreatic diversion, restrictive is your sleeve gastrectomy and gastric banding, and hybrid includes roux-NY gastric bypass and omega gastric bypass. Now let's look at the images of them. So in this we have a gastric bypass, right? So if you see that this is the bypass portion of the stomach, the esophagus, the proximal pouch of the stomach, and it is a short intestinal limb, pylorus, duodenum, the biliopancreatic limb, and the alimentary limb. So over here, if you see that a roux-NY gastric bypass, a short bypass, has been made between the ileum and the alimentary limb, right? And on the other hand, you see that over here is again your bypassed stomach, and this is your bypass small intestine, and this is your new gastric pouch created. So basically this is a one anastomosis thing, like with a gastric jejunostomy reconstruction with the one anastomosis gastric bypass, right? So over here you have a short vertical lesser curvature, and over here you have, sorry, in this one you have a short vertical lesser curvature, and in case of this you have a longer vertical lesser curvature, right? So this is the one anastomosis gastric bypass, omega gastric bypass, which is a recent gastric bypass. Now this is an image which has been taken from the recent edition of Bailey and Love. So I would like you to notice over here that there's a biliopancreatic diversion. Now first, on this diagram, a biliopancreatic diversion with the duodenal switch variant, right? So if you see that the alimentary limb over here is around 100 to 250 centimeter, this is your biliary limb, and this is your common channel, which is your 75 to 125 centimeter. Now a recent update has been the single anastomosis duodenal-ileal bypass with sleeve gastrectomy. So if you see that there is an end to side duodenal-ileostomy which is being done over here, right? So what is the main advantage over here is that you are able to preserve the pylorus, right? So this is an important question which can be asked, as it's mentioned in your new Bailey and Love also, that because of this end to side duodenal-ileostomy you have the pylorus preserved over here, which is not being able to preserve in this traditional biliopancreatic diversion. Now next important question which is asked in your bariatric surgery is regarding your complication. So I've taken this table absolutely from your Bailey and Love. So you have first or your sleeve gastrectomy. The complications could be either early or late complication. The early complication include leak at angle of his, intra-abdominal bleed, DVT or pulmonary embolism, right? And the late complications would include gastroesophageal reflux, Barrett's esophagus, and weight regain. The gastric bypass complications would include anastomosis leak, which is usually less than 1%, intra-abdominal bleed, unspecified obstruction, and again it could also cause deep venous thrombosis and pulmonary embolism. It can cause late complications like internal hernia, chronic abdominal pain, malnutrition if there is a long limb bypass, and anastomosis, ulcer or stricture, and weight regain. The complications of the gastric banding would include the access port infections, DVT or pulmonary embolism, and it would also cause band infection, tubing leak, slippage, or erosion into stomach, band intolerance, and failure to lose weight or weight gain. So this is some of the important points that you need to remember in bariatric surgery. You will be usually getting straightforward questions. You might be asked regarding your identify the type of procedure. Please remember the single anastomosis duodenal ileal bypass with sleeve gastrectomy, which can be asked as it's been mentioned in your recent Bailey and Love. Now the important differences would be the common channel, which is 75 to 125 centimeter, and in this case the common channel would be 250 to 300 centimeter, and the pylorus is preserved. Now this is your gastric bypass, one with a single anastomosis and having a greater curvature. Which one? The lesser greater curvature, right? Greater lesser curvature. So let's rather simplify, rather complicate it for you guys. It would be a short vertical lesser curvature, and it would be a long vertical lesser curvature, right? And the important types of bariatric surgery have been mentioned, and the indications, please remember BMI more than 40 and BMI more than 35. BMI more than 40 with or without any comorbidities, and BMI more than 35 with comorbidities. Now let's